Good evening, friends. A warm welcome to all the faculty and my dear students. So we have eminent faculty today joining us from across the country. Today we have two interesting exam cases for discussion. So we have Professor Dhyanesh Balekar sir, Professor of Surgery and Head of the Department at Terna Medical College, Mumbai. Professor Sharvari ma'am, he is a additional professor of surgical gastroenterology from KIM Hospital, Mumbai. And we have Professor Jishan Ahmed ma'am. She is the HOD surgery from Assam Medical College, Dibrugarh. We have Professor Sudhir Kichi sir, again head of the department from Guru Gobind Singh Medical College, Faridkot, Punjab. And we have another eminent surgical gastroenterologist, Professor Prasad Krishna from SNIMS from Kochi, Ernakulam. And we have two bright students from one from Tagore Medical College, the other from Coimbatore Medical College. Today it will be a GI session. We are going to have right upper quadrant mass and one case of left upper quadrant mass to be presented. Now I leave the faculty to choose which quadrant you go first, right side or left side, so that I will ask the candidate to present. Professor Sudhir sir, please suggest which candidate can go first. Dhyanesh sir.
We should start. Thank you.
It is fine.
Which one to go first, sir?
Right.
Right side. Perfect. So that makes Prem to go first. Prem is kindly contributed by Professor Loknathan sir and Professor Jawahar sir. He is from Tagore Medical College. He is a PG resident from there. Kanna sir and other senior Karnakaran sir, Rajiv sir, welcome sir. So, good evening sir. So let us have the first postgraduate, Prem. Prem, you please share your screen. The arrangement will be the candidate will be allowed to present without stopping till the history part is over, and the faculty can take them back from the first slide to revisit and question them. We have our own panel who have been with us for the last 3 years, and they'll also be chipping in. And I will request the faculty, invited faculty, to take priority and take through the discussion. Each case have 1 hour of time. So I request the faculty to give the answers if the candidate find difficult to answer your question or not answering to your satisfaction. So this being a teaching forum, and help them to learn, and the students who watch in the YouTube channels also to learn. Thank you very much. Good luck, Dr. Prem. You make it into full screen and start your presentation. All the very best to you.
Thank you, sir. A very good afternoon to very good evening to one and all present here. I am Dr. Prem Kumar, final year postgraduate from Tagore Medical College from Department of General Surgery. My chief is Dr. Loknathan sir, and HOD sir is Dr. Jawahar sir. This is a case of right hypochondrial mass. A 52-year-old female hailing from Kolapakam, housewife, came with complaints of swelling over the right upper abdomen for 5 months and pain over the right upper abdomen for 1 month. History of presenting illness. Patient was apparently already 5 months back. Then she started to feel a mass over the right upper part of the abdomen, which was insidious in onset, gradually in progressive. Initially, it was a smaller size and gradually progressed to attain the current size. And then also patient complains of pain over the right upper part of the abdomen for 1 month, which is a dull aching type, which is insidious in onset, intermittent type, 3 to 4 episodes per day, gradually progressing, and it was radiating to back. The pain precipitates after taking food and relieved by medications, and it was not associated with any change, postural changes. There was history of a loss of appetite and a loss of weight of approximately 5 kg for the last 3 months. History of easy fatigability was present for the past 1 month. No history of fever, vomiting. No history of passing clay-colored stools or high-colored urine or yellowish discoloration of sclera was present. No history of generalized itching. No history of hematemesis, melena. No history of any other swelling anywhere else in the body. no history of altered bowel habits, no history of progressive abdominal distension, no history of breathlessness, hemoptysis, and no history of seizures, chronic headaches, or projectile vomiting. Coming to past history, no history of gallstones, cholecystitis in the past, no history of blood transfusions done in the past, no past surgical history. Patient is known diabetic and hypertensive on regular treatment for the past 3 years. Personal history, he consumes mixed diet, sleep is normal, bowel and bladder habits are normal, not a non-alcoholic smoker or any history of any other substance misabuse. And there was no history of travel to Oriental countries. Obstetric history, she was married 30 years back and has 2 female children. She attained the menopause 2 years back. Family history, no history of gastrointestinal tumors in the family. Summarizing, a 40-year-old female with complaints of right upper part of the abdomen mass for past 5 months associated with dull aching pain, which is radiating to back for past 1 month, with history of a loss of appetite and weight approximately 5 kgs for the past 3 months, and easy fatigability and weakness for 1 month.
Dr. Prem Kumar, right? You said you've spoken about the lump, but
Yes, sir.
you should give us an approximate size. What was it? I mean, we don't know. You said small size to now whatever it is. We don't have an idea. It could be a size of a full football, for all we know.
Yes, sir.
So that should be clarified.
Okay. Initially, it was around when she started noticing, it was around 2 into 1 centimeter swelling. Now it attained to the present size of approximately some 5 into 5 centimeters.
So say that. I think
Yes.
that will be appreciated a lot.
Yes, sir.
Okay. So please.
Dr. Prem,
Yes, ma'am.
I will just tell you a few tips, okay?
Okay.
Okay, so you said I think this history is taken by you, right?
Yes, ma'am.
And the slides are prepared by you yourself. It is not given to you, right?
I am liberated.
So what we have to do is, it is okay to tell the history in the patient's language in the first part of the introduction or first part of your speech, right? The patient has the complaint of pain in abdomen, right upper part of abdomen, right?
Yes.
So when you repeat it, you can say it in a better words like right hypochondriac region.
Okay.
We know the quadrants of abdomen, and we can, even if the patient says on the right side upper abdomen, then you can change it better in better words on the next time, or while repeating it, you can use the word like right hypochondriac region, right?
Yes.
This is
Okay.
the first. Second, you have to definitely use the words lump and swelling judiciously and differently. What is swelling and what is lump? When you call it as swelling, or when even if the patient says again swelling,
So,
then you have to tell it as lump abdomen,
Lump.
right? What
lump
there
of the
is there inside the abdomen, the swelling is something which is outside. This we have learned in the MBBS also.
Yes.
Right. So what is there on the surface is the swelling, and what is there, if the swelling is there inside the abdomen, then we call it as lump in abdomen.
lump
So it would be better to tell as lump in the right hypochondriac region.
region. Okay.
Yes, that sounds better. That sounds surgical words.
Yes.
But patient may not tell you this. Patient will tell that she is feeling. So, okay, so these are the two things. Then patient feels the swelling. Patient feels the lump now, and then you have to. She cannot feel the lump and suddenly. So she will feel something is there. Then she will feel on the next day. Then the lump is progressively increasing. So you can tell it as a story.
Okay.
Dr. Prem Kumar.
Yes, yes, sir.
Actually, the history is your interpretation of what the patient says, right? So you can use medical terms to describe it.
Yes, sir.
Also about this lump and swelling, and there's another term called mass,
Awesome.
right? So if it's a tumor or a swelling within a cavity which cannot be palpated or seen, is called a mass. A lump is on the skin, and swelling can be anything. Can be generalized swelling,
Generally.
can be a swelling of the arm, right? So it's a lump, a mass, and a swelling.
Okay. Yes, sir.
Right, sir, please.
Dr. Prem,
Sir.
can you go back to your second slide? Okay. Now, when you are taking a history and presenting in the exam, as far as possible, you should remain focused and avoid vague terminology. Now, what you have mentioned, that patient was apparently all right 5 months ago. It is okay.
Okay.
Then she started to feel a mass. Now, what do you mean feel a mass for the patient? Was she feeling a sense of heaviness in the abdomen? Or was it a painful thing? What is the feel part as such?
Okay.
We cannot use arbitrary terms like feel or mass over right upper part of the abdomen. That is one part. Second thing, you have mentioned it is gradually progressive. Initially of small size, as
Initially small size.
others have said, you should have a rough comparison. Say initially maybe a small
Initial
size of
small
an
size of
apple, and then
lemon.
it has grown to a size of maybe a small football or something. Something like that to have a comparison.
Okay.
Next important
Approximate
point
size.
is when you mention gradually progressive. Now, what do you understand by gradual progression? Can you please tell?
So initially it was
5 months, a
this-
lump is becoming from 5 centimeters to 15 centimeters. Is it a gradual progression or a rapid progression?
it is 2 into 1. Initially it was of 2 into 1 centimeter swelling. So
No,
for the
my point is, to be on safer side, it is always better if you use the terminology. The swelling has progressively increased from its initial dimensions of a size of a small apple to its current dimension of size of a small watermelon or something like that. That will give a clear picture to the examiner.
Okay.
Understand?
Okay.
Gradually progressive means what? Gradually progressive means progressing over the last 20 years, 10 years, right? That is what
Okay.
we call it gradual progression.
Gradual progression. Was it
When you are
fast?
anticipating
long
or
period.
giving your diagnosis as a malignancy, or at least keeping one of the option as malignancy, it can be gradual progression, especially when the size is small. And now, as per the later photograph, what we may show, this is a large, huge swelling, correct?
Yes.
So dimensions have grown exponentially in 5 months. So that is a rapid progression for the patient.
Rapid progression. Okay.
So please be specific and do not make such very simple mistakes at the PG level. MBBS level, okay, we may let go the student, but for PG level, it will be important that try to avoid the mistakes.
Okay.
Second thing you have mentioned, patient complaints of pain over the right upper part of the abdomen, which is dull-aching type, incidence of intermittent, per day, gradually progressive, radiating to the back, dissipate after the food and relieved by medications, and not associated with any postural changes. Okay, so what is your here you are anticipating?
So it is of more likely of a biliary origin.
Biliary?
Biliary.
Okay. Could it be a stomach pathology? Pyloric part?
So it could be also pathology.
See, one very important thing for all the PGs that keep your mind open in exam. Do not have a limited horse vision that, okay, this is someone has prompted, this is a case of a biliary malignancy. So your vision, lateral vision shrinks.
Okay.
You cannot think openly. Even if the time is less for exams, it is always better approach to have a focused and open approach with the patient. Fine? That will be helpful to you.
Yes, sir.
So please progress. Next slide. Okay, now here you have mentioned a lot of negative history as such, and mainly history of loss of appetite and loss of weight.
Yes.
So that is okay as such. Next slide. Fine. Next slide. Okay. Fine. Next, please. Okay, now see, here you are mentioning patient consumes a mixed diet, right?
Yes, sir. It's
Bowel bladder habits are normal.
normal. Yes.
Now, such a large right hypochondriac mass pressing maybe on the hepatic flexure or some part of the biliary tree. Patient will have some or the other uh, alterations in the food habits or food
Yeah.
patterns that you have to mention very importantly and judiciously.
Patient, she doesn't have any altered bowel habits.
That's okay,
Her
fine.
bowel bladder.
Yeah, but when you're anticipating biliary tree, patient will have acute pain, right? You mentioned.
Yes, sir. Okay.
Correct. So that in that context, you have to mention accordingly in connection with the biliary tree, since that you are anticipating as a first choice of your option as such.
Okay.
So you think about that also very important. Next slide, please. Okay, that's fine. Next slide. Next one.
So can you able to see the screen, sir?
No, yeah, family history fine. There, you said there is no family history of any GI tumor. That is okay. And now what are GI tumors? Do you know? With familiar presentation.
Sir?
What GI tumors familiar in origin you are anticipating here when you are asking the history, no history? What you want to rule out basically?
No. No stuff with any pancreatic cancers.
Pancreatic, okay.
Pancreatic cancers. Pancreatic and
Even
Prem
hepatic
Kumar,
biliary
Dr.
also.
Prem Kumar, you have been asked on GI. So they come up with the more common ones. Don't restrict yourself to hepatobiliary because your case is that.
When you're mentioning about GI tumor, you have to mention about the GI tumor, no?
colonic cancers, the stomach cancers.
Okay. Proceed.
No, you want to tell something about associations of GI tumors with the what pathology you are thinking in gallbladder?
Gallbladder is so
So
generally
indirectly, he wants to say what are the GI tumors which are having some association with, or biliary tumors which are associated with the gallbladder tumors.
Tell him the answer, please. I think he doesn't know.
no history of any colonic malignancies and pancreatic cancers in families. Or
Okay, move on.
Proceed.
I would just like to make a few corrections here. Dr. Prem Kumar, so with
yes.
this comparing of swellings with oranges and apples is not done anymore. We've got, should be an objective one. You can interpret the size in centimeters.
Okay, sir.
Also, right? So I think that's more expected. Tell me, what is melena? You said there's no melena. What do you mean by melena? And why did you ask for melena?
So to rule out any GI pathologies, so black colored tarry
Okay,
stones,
define Dr. Prem Kumar, define melena first.
passage of black colored tarry stones.
Right. So why does that happen?
So in case of any upper GI bleed,
Only upper GI bleed? Only upper GI bleed?
Upper and lower.
Okay. Why did you say upper GI? Okay. Why did you say upper GI?
Any, if there is any tumors and tumors from the upper GI, if it gets bleed and then
Dr. Prem Kumar, Dr. Prem Kumar, why do upper GI bleeds lead to melena and not lower GI bleeds?
Lower GI, it will present as dark red.
No, answer my question. Why do upper GI bleeds usually lead to melena and not lower GI? If you know it, you tell me. Otherwise, I'll tell you the answer.
Usually,
Do you know the answer, or should I tell you?
No.
Right. So because of the acid in the stomach is converted to acid hemetin, which is black in color. Right. So if there is low transit time, also when the blood gets time to react with the acid, even when there's low transit time, then also melena can happen. Right.
okay.
And if there's less blood bleeding less than 60 ml per day, it is known as occult blood. If there's bleeding and still the stool is normal, it's called occult blood. Sir, please.
Yes.
Prem, do you know what is right hypochondrium? What do you understand by right hypochondrium?
Right. The reason, so the abdomen is divided into 9 quadrants.
Yes.
And, 9 transtubercular and the subsequent, and then bilateral and multilateral line.
Why did I ask this question from you? Well, there must be something in my mind that I'm asking this question from you.
So for differential diagnosis.
No. It's about the size, sir. It's about the division of the abdominal wall, anti-abdominal wall. Any other division which you can do to satisfy Professor Khanna? Are there 4 quadrants?
4 quadrants.
Yeah. So why is he asking this now? Now you tell. Why has he raised an objection to right hypochondrium?
The mass originating from the abdominal serum.
Okay, let me tell you about that. You know? Hypochondrium is a very small component, very small. Hardly it is 1 to 1.5 centimeter only. Because majority of the hypochondrium is below the subcostal margin. Okay, it is up to the diaphragm. But that is not palpable clinically. So it is only about a centimeter of the lump which will be there, you can feel in that area. So majority of the time when you are feeling a lump in that area, so either you say it's the right upper abdomen or this lump is extending to the lumbar region.
Okay.
If you say it's 4 or 5 centimeter mass which is there, then it has to be in the lumbar region or in the right upper abdomen, including the right hypochondrium. Okay, so right hypochondrium is a very small structure. It's only 1 to 1. Similarly, the left hypochondrium. Majority of the left hypochondrium is below the costal margin.
So most of the
Now, you said the gastrointestinal tumor here. Hello.
Yes, sir. You're audible, sir.
Yeah, Prem. You said the gastrointestinal tumors. You know, whenever you use this term gastrointestinal tumor, the immediate impression in the mind is that you are talking about the gastrointestinal stromal tumor. Okay. But otherwise, nothing like the gastrointestinal tumor. It has to be from the stomach duodenum, or it is from the small bowel, or it is from the large bowel. Okay. So this term is not good term, gastrointestinal tumor. And in your case, if you are saying about that, that area is not for the gastrointestinal area. Okay, it is for the liver, or it's for the pancreas, it's that area which is there.
Okay.
And then why did you ask about traveling to the Oriental countries in this patient? What is the reason for that?
History of any travel to Oriental countries to know the exposure about the Oriental cholangio infective clonorchis sinensis.
Hmm?
So probably there may be a probability of infection of clonorchis sinensis, which is more prevailing over the oriental countries like China or Russia and Vietnam. So that may be a probable causative factor in this.
This is just beyond the imaginations you are talking about that. You know? These are the things, probably it is not, you have to think of the common things there.
Common things.
Not the oriental countries and all those. Okay.
Okay.
Prem, actually, one question is, you told it's precipitated with food intake. It is better to elaborate on the type of what exactly the food, how long the pain remains there. So how will you differentiate duodenal ulcer pain from a gastric ulcer pain from a hepatic type pain? How can you differentiate?
Gastric ulcers, so the patient will be having experiencing pain immediately after taking food. In duodenal ulcers, the patient will experience pain after some time, 10 to 15 to 20 minutes after taking food. And in a biliary pathologist, patient will have postprandial illness, postprandial satiety immediately after taking food.
So usually, so you have to mention what exactly aggravating factor and relieving factor.
Relieving factors.
So in a gastric ulcer, food intake aggravates pain, and so usually they will do an induced vomiting to relieve the pain.
Yes.
In a
Yes,
duodenal ulcer, food intake relieves the pain.
relieves pain.
So who will have a nocturnal type of pain? When the stomach is empty, duodenal ulcer pain will have a nocturnal pain. Whereas in a hepatic type pain, when there is a tumor, so there is a dragging sort of severe pain will be there. That is more characteristic when the Glissen's capsule is expanding. So that is a sort of pain that patient will have, a hepatic type pain. So you always keep your mind open-minded and rule out all these things. When you're history taking itself, you mention all these things. So one question was whether it is a origin from the stomach. So you should have you have to rule out all these things. So from the history taking, from the basic, what is the type of pain, you have to evaluate and rule out all the things. Okay, don't take any diagnosis before, because you don't think much after that. So your brain stops thinking. And if you don't know any answer, you tell I don't know. No one is going to penalize you. If it is don't know, please tell I don't know, sir. Okay.
Okay.
I have Professor Mansoor sir's hand going up. Sir, would you like to ask any questions, sir?
No. Regarding this food habits, even you see the biliary pain, any composition of diet is important. So far as this biliary pain is concerned,
Fatty consumption of fatty
so
foods.
you should come out. You should come out that there is no history of pain while after taking fatty meals or dyspepsia or fatty meals. Right. So that's also very important.
Okay.
So Prem, keeping this history in your mind that the lump came first, followed by pain, followed by loss of appetite.
Yes, sir.
So what are the things you are thinking in your mind? Based only on the history.
So based on this history, most probably the mass may be originating from liver or gallbladder.
From liver or gallbladder.
Gallbladder, yes, sir.
So tell in which condition you will get the lump first, followed by pain, and in which condition you will get the pain followed by the lump.
In gallbladder malignancies, first lump will be visible, and then it will followed by pain.
Okay, good. Yes. And where you can get the pain first and then followed by the lump?
In cholangiocarcinoma. in cholangiocarcinoma.
Why you are thinking in terms of cholangiocarcinoma for pain followed by the lump? Tell a very simple thing which is there. What is the commonest cause of pain in that area? Biliary colic, isn't?
Biliary colics.
Followed by it may be only a mucocele of the gallbladder may be there, or it may be a empyema of the gallbladder may be there, or it may be itself just acute cholecystitis is there. All will form a lump in that area.
Yes.
Okay.
Okay.
And for that matter, even gallbladder malignancy lump cannot start with the painless. It cannot be always painless. It may have a preceding history of biliary colics or right upper quadrant pain.
Quadrant pain. So patient may have on and off biliary pains, but mostly it will
Gallbladder malignancy can present as acute cholecystitis, sometimes chronic.
Cystitis also.
Various ways or asymptomatic also.
Yes,
Just on evaluation you find. So there is various presentation of gallbladder malignancies.
You can go to the examination now, yeah.
Okay.
Dr. Prem? Dr. Prem?
Sir?
You have described about the loss of weight.
Yes, sir.
That's also very important history. So what do you think the significant loss of weight is?
Significant loss of weight is more than 10% of loss of weight over the past 6 months, or
okay,
more than 5% loss of weight for the past 3 months, or more than 2% loss of weight in the past 1 week.
Okay. So did this patient had that much loss of weight?
And also, patient is actually obese, so he gave history of loss of weight of around 5 kgs in the past 3 months. So, which is not a significant.
Okay. So proceed to examination.
Okay. Now, going through the general physical examination, a patient was examined after taking consent in daylight after adequate exposure and supine position. So the colonoscopy performance scale was 80. The patient was conscious, oriented, obese with a BMI of 28. Pallor was present. No interest, cyanosis, clubbing, spherical edema, generalized lymphadenopathy. No signs of liver cell failure was present. Supraclavicular fossa, no fullness seen. The oral cavity, no abnormality noted. Vitals, blood pressure 130/80 millimeters of mercury. Pulse rate 82 per minute. Respiratory rate 18 cycles per minute. And temperature was 98.4 degrees Fahrenheit. It's a clinic picture of the patient. Systemic examination for abdomen. On inspection, abdomen not distended. Umbilicus centrally placed and inverted. Right hypochondrial fullness seen. Globular mass noted in right hypochondrial region, measuring 5 into 5 centimeters, extending 6 centimeters from right costal margin and midclavicular line, with smooth surface, most with respiration. Stretch marks noted over the lower part of the abdomen. No visible pulsations or engorged veins or visible pulsations noted over the abdomen. All quadrants moves equally with respiration, and the hernial orifices were free. On palpation, no local rise in temperature over the abdomen noted. A single tender palpable globular mass was noted in right hypochondrium region, approximately of size 6 into 6 centimeters, which is hard in consistency with irregular surface, margins extending 2 centimeter medial and 6 centimeter lateral to right midclavicular line, and extending
again, Dr. Prem, stop here. This is what I think the senior professor was pointing out about the right hypochondrium. Again, you are making the same mistake. How can a 6 into 6 centimeter lump can be present only in the right hypochondrium?
right hypochondrium and epigastric region. And
So it must be extending around.
extending as well.
Right. So you have to
Yes.
describe it in that way, that this was a lump which was extending from right hypochondrium to
hypochondrium.
lumbar. Right. Right. So this mistake has to be corrected
Okay.
because such a large lump cannot be localized to
Localized to
the
the
right
right
hypochondrium.
yes. So it extends into the epigastric region also, and lumbar. A single tender palpable globular mass was noted in the right hypochondrium region and extending to epigastric region approximately of size 6 into 6 centimeters, which is hard in consistency with the irregular surface, margins extending 2 centimeter medial and 6 centimeter lateral to right mid-clavicular line, and the extending 5 centimeter inferior to subcostal margin. Borders were medial, inferior, and lateral borders were well defined. Superior border was not palpable. So the swelling was can't get above the swelling. Fingers were not able to insinuate between the swelling and right subcostal region. Mass moved craniocaudally with respiration. Plane of the swelling is intra-abdominal and intraperitoneal with no intrinsic mobility. No spleen was not palpable. No other mass palpable in the abdomen. On percussion, liver donors noted from fourth intercostal space in the right midclavicular line till 2 finger width below the right costal margin. Liver span was 13 centimeters. Impaired note on percussion over the mass, which is continuous with the liver donors, and no signs of free fluid was present. On auscultation, normal bowel sounds heard. In perectal examination, normal sphincter, no mass palpable, no abdominal shelf notes were present. Other systemic examination, cardiovascular system, respiratory, and CNS were normal. To summarize, middle-aged female with right upper abdominal mass, right hypochondrial mass for the past 5 months, and with dull aching pain, it is radiating to back for 3 months, with history of loss of appetite and weight of approximately 5 kg in the last 3 months, with easy fatigability. And on examination, revealed a hard, tender globular intraperitoneal mass of size 6 into 6 centimeter with a irregular surface originating from right hypochondrium and extending to epigastric region, which moves on with the respiration.
How can an irregular surface can be a globular in size? Globular means a geometrical shape, no? It can't be irregular. They are contradictory, no? Say irregular, that's all. Don't say globular.
Okay. Irregular mass.
They are contradictory, no?
Yes.
Yes. Again, you keep saying right high. You don't want to change your concept. It is involving the right lumbar region, right epigastrium.
Right epigastrium.
Why don't you correct yourself? Why you want to keep on saying the same thing, even after your mistake is pointed out?
Right hypochondrium, mass extending.
It's a very common error very common mistake in the examination. It's very common, where you don't identify the boundaries. Yes, carry on.
Dr. Prem, go back to your first slide of examination. Next. So here you can see you see on inspection also, you can see this lump which is extending much beyond the.
But also to the umbilical.
Also to the, you see, umbilical region. So during you see examination, this is very, very important that you describe the extent of lump. So this is the basic, right? Next slide. So in a lump which you presume that it's you see a gallbladder lump, why you want to see the umbilicus? Anything special in the umbilicus you can feel?
So in the presence of ascites, so the abdomen will get distended and umbilicus will be able to.
Anything more than ascites?
Any nodules?
Yes, some nodule.
Nodule.
What that nodule is called as?
Cisternaries nodules.
Okay. Okay. So you have written right hypochondrial fullness. So this fullness is again extending. You have to describe it. This fullness is extending to all those surrounding
right, lumbar and epigastric
right
regions.
Prem, in which position you have examined the patient?
The patient was examined supine.
Only supine?
Yes.
Any other position you would like to check the patient?
And left decubitus.
Would you like to examine her in standing position or no? Can she stand?
Standing position.
Have you bothered to check? Okay, one more thing. Regarding, can you show the photo again of the lung?
Yes.
Is the exposure adequate? What is the adequate exposure for examining for abdominal case?
From the nipple to the level of the nipple till groin region.
In mid thighs.
Groin, mid thighs.
Mid thighs, no?
Mid thighs, yes.
So exposure should be adequate in a controlled environment, maintaining patient's privacy, and preferably in two positions. One is standing position and second in supine position. Any change in the dimension of the swelling spontaneously, you need to note down.
Okay.
And as everyone else has mentioned very clearly and correctly, and plus you also see the lump is almost occupied right corner of the abdomen, not just quadrant, which is engulfing the epigastric region, part of umbilical region, entire lumbar region also almost. So almost a quarter of the abdomen, if you just divide arbitrarily before, it is gone, right? Yes. So as others have mentioned, please try to modify the type of presentation when you are proceeding. Do not restrict yourself to the same terminology, right hypochondrium, right hypochondrium. Okay? Please proceed. So the next time. Okay. Okay.
What is tenile sign? What is tenile sign relation to umbilicus? Upper abdominal masses, the umbilicus moves downwards, whereas lower abdominal masses, it may be shifted upwards.
Okay. Okay.
That is tenile sign.
Yeah. Okay.
Okay.
Next slide.
No, the previous slide. What do you mean by local rise of temperature?
Warmth, there's no warmth localized.
Local rise of temperature, you mean the temperature around umbilicus, temperature around the, where? What do you mean by local rise of temperature?
Around the mass.
Around the mass.
Around the mass.
Should it be used anymore? Especially in abdominal masses.
Dr. Prem Kumar, we don't use local rise of temperature in the abdominal wall unless it's on the in parietes. It's in the parietes, you got an abscess, you can say that.
Right. Parietal wall swelling is okay.
Right. Okay. But it's the intraperitoneal lump or intra-abdominal lump, we don't say this. Okay.
Okay, sir.
Okay, so Dr. Prem.
Sir, yes, ma'am.
So I think with the little, I'm on the side of Dr. Prem that he has quite well defined and described the mass in the. Except a few corrections you have to make, like the extent of mass and all. So what point is that now there is a mass, though. So what comes to your mind now? What you want to convey to examiner is the location of the mass and from which organ this mass is originating, right?
Yes, yes, ma'am.
So with this information, what is your differential diagnosis? Now let's proceed to the next. That rest of the examination we hope is the normal with the normal findings. So with these
Yes.
findings, with this lump in abdomen and with this history, what are the differential diagnosis?
With this examination, probable differential diagnosis will be carcinoma gallbladder.
No,
then-
you can do carcinoma gallbladder directly. Why carcinoma gallbladder? First of all, carcinoma gallbladder is a pathological diagnosis, right?
Yes.
So let us elaborate. So tell us what organ this mass is originating from, you think, and what could be the pathology?
So most probably of liver and biliary
Diagnosis.
pathology.
Not how the it should
Dr.
not.
Prem Kumar, sorry, you think it's a gallbladder? Now, why do you think it's a gallbladder?
Since, the swelling is globular in shape.
There's nothing called globular. You just say it's the shape of a gallbladder.
Gallbladder and the shape of gallbladder.
So
What
in
else?
this region,
else?
in this with such a shape and such a swelling, what it could be? It could give me 2-3 diagnoses, 2-3 at least organs and 2-3 possibilities. What this swelling could be?
This swelling could be a mucosal of
There are
gallbladder.
all types of swellings of the gallbladder, isn't it?
Yes.
Why you are there still right on the gallbladder? How many cases now? Let us go to discussion. How many times such a huge mass is palpable from the gallbladder without jaundice? Even if you know
Really
the
slightly.
diagnosis, you have to tell that, sir, there is a mass in this region. So it could be from liver, it could be from gallbladder. Mostly it is not from the luminal luminal tract.
Is the mass continuous with the liver or is it discontinuous with the liver?
The mass is continuous with the liver.
Yes.
So there,
So
so
it could
another
be
differential diagnosis now.
it could be a Riddle's lobe of liver.
Oh, come on. You can't have a Riddle's lobe of such large size out there.
Is the Riddle's lobe hard in consistency?
Can there be something else rising from the liver?
Something.
Can it be a hepatic tumor? Can it be hepatic
Hepatic tumor.
abscess? Can it be hepatic? Come on.
Hepatic,
Can it be FNH?
liver tumors, possibility of liver tumors also.
Yes.
What is
So you
FNH? Dr. Prem Kumar, what is FNH? Ma'am said FNH.
Focal
What is
nodular
FNH?
hyperplasia.
Focal?
Nodular hyperplasia.
Yeah, very good. Very good.
okay. So now tell me, what are your differential diagnosis? Or what is this lesion probably?
So the differential diagnosis may be hepatocellular carcinoma.
Oh, Dr. Prem Kumar,
Again,
don't change your diagnosis just because ma'am's told you. If you think it's a gallbladder, you say it's a gallbladder. Other things could be so and so.
Okay.
Right?
Your provisional diagnosis should be towards gallbladder, as ma'am has said. That, and second, you can keep all these remaining liver swelling.
The differential diagnosis.
I think
Right.
to answer it as a tumor arising from gallbladder, most probably malignant etiology.
Tumor.
Right? You cannot it is carcinoma gallbladder, then one will ask you why it is gallbladder and why it is malignant. Then you have the favoring points towards gallbladder and malignant because it is recent onset along with the weight loss and loss of appetite and all those things, hard inconsistency. So it is always better to say gradually and in a broad manner rather than directly hitting to carcinoma gallbladder or it cannot be like that, right?
Okay,
Dr. Prem, Dr. Prem, what is gallbladder mass? Or gallbladder lump? How you define it?
The lump originating from the wall of the gallbladder.
Okay.
Extending to the surrounding region.
You think it is such a big lump can only originate from the gallbladder?
Patient will not survive with such a big gallbladder tumor.
Prem, always keep a
Yes.
differential diagnosis. So if there is a gallbladder mass is there, or it could be from the lower border, as from the liver also there is a possibility, or something that is all 2 or 3 differential diagnoses always keep in mind. And always there are positive things and negative things, for and against will be there, that you can elaborate. So here also there is an irregular mass is there. So, and the location, that's why you think of a more sort of gallbladder malignancy. Again, it could be a liver tumor that is arising from the liver is another possibility. So all the differential diagnosis, keep yourself and tell what are the points for and points against the diagnosis.
Okay. What about renal swelling? You see, when the swelling is entering into the lumbar region, you not mentioned about the bimanual palpation. Very important. Suppose this is a renal mass. Should come into the differential diagnosis, no?
So tumor extending to right lumbar region.
Yeah, anything coming into the lumbar region, renal mass should come into the differential diagnosis automatically.
So Dr. Prem, was the examination
Dr.
of
Prem
back
is
not
not
important? So here comes the examination of back, renal angle, bimanual palpation. So no examination is complete without examination of back.
Correct.
Okay, sir.
Actually,
so
Loin mass.
Anything. Right.
Loin mass without bimanual examination is not complete.
Yes, such a huge mass which is occupying almost whole of the lumbar region, extending to umbilicus, to umbilical region and hypochondria.
Could we progress to his management now? We just don't have time.
I think
faculty,
so.
I'm sorry. I request you to give him a working diagnosis. I understand he has challenges, sir, but we have another 10 minutes or so left so that he can take it further, sir. So I request the faculty give him a working diagnosis and they take the discussion further, sir. Sorry for interrupting you.
Okay, now carry on with the management.
Dr. Prem, I think it's your gallbladder, carcinoma gallbladder. Now continue.
Okay, sir.
It is moving with the
Next.
Okay, Dr. Prem, now what are the how will you work out this patient now? How will you confirm that this is a gallbladder mass?
So first, I would like to do a basic routine investigations, like LFT.
Dr. Prem Kumar.
Now consider 5
investigation to confirm your diagnosis.
and go on to
Investigations to stage the disease.
give you diagnosis.
Then investigation to prepare.
I would like to do after routine blood investigations. I would like to do ultrasound abdomen followed by ultrasound abdomen for the tumor tumor origin and then surrounding structures, and then followed by a CECT abdomen for staging the disease.
So what do you find in ultrasound? Do you have the report with you?
Yes, sir.
Ultrasound CT report. You show the pictures, Dr. Prem.
So I have CT videos.
So
this is
what are the
CECT
findings on ultrasound? So this is a CECT. What about the findings on ultrasound?
On ultrasound, there are multiple foci lesions over the liver. So gallbladder wall thickening with multiple focal lesions over the right and left lobes of the liver. So
in other words, what are your findings you expect in ultrasound in a CA gallbladder?
So there will be irregular, there will be wall thickening of the gallbladder with irregular shaped swelling.
Anything else?
Heterogeneous mass with the asymmetry of the thickening of the gallbladder.
Does it tell you the infiltration into liver?
Infiltration into liver and the status of the common bile duct. and presence of ascites.
Okay. Gallstones, presence of gallstones.
Gallstones.
Anything else? So you have to keep your mind open when you are describing, you see, the role of ultrasound in the gallbladder malignancy.
Yeah. And then the liver mets also, secondaries in the liver will be appreciated in also.
Or anything else? Okay, okay. What next?
So next, for investigation of choices, CECT of the abdomen.
Okay.
Will you get some investigations done before you want to get a CCT abdomen?
Or I like to do RFT, renal function, urea treatment. So this
Get a general workup done. Okay.
Yes, general workup.
Right. Why do you want a CCT? Ultrasound is telling you that it's a liver mass, it's a gallbladder mass with secondaries in the liver.
So after confirming by pathology, so like to for staging the disease, will be needing a CCT.
Okay.
Can you think of a better investigation than CT abdomen for staging? What about a PET scan?
PET scan also can be done.
Not can be done is not an answer at all. Will you
So
do
initially,
it or not?
No, I think we would prefer a CCT before we go in for a PET. Definitely.
Yeah.
Dr. Prem, Dr. Prem, is there any condition where you think, no, ultrasound is sufficient and I'll not go ahead with the CT scan of abdomen? This is sufficient. I have got sufficient evidence that this is this, and I'll not go ahead with CT scan. Dr. Prem.
Porcelain gallbladder.
Right? When you say that ultrasound is sufficient, I'll not go ahead with CT scan. No, ultrasound is sufficient that now I'll not go ahead for CT scan. Only ultrasound is sufficient for such thing.
If the tumor is confined to a
Prem, why are you taking CT scan? What is the main aim of taking a CT?
CT, yes.
What is your main aim for
to get a CT scan done? Yes.
You're planning for resectability. Yes.
So for
resectable.
So to decide upon whether a tumor is resectable or not, and then to get about the any vascular involvement, and then to stage any for any look for metastasis. Okay.
So if you are, if Dr. Prem, if on ultrasound you have a gross ascites, multiple mets in the liver, multiple lymph nodes infiltrating here and there, what your CT will do now? It's already a advanced disease. So still you want to go for CTC?
It is only an academic at that time.
So when on ultrasound you have already a advanced T4 disease, advanced with the mets and gross ascites, I don't think there is any need to go ahead for CECT. So CECT will be, just as sir has pointed out, only to see for resectability and staging. Okay, proceed ahead with CECT.
Dr. Prem.
Sir, I would like to add up a point here. Sir, in case if the patient is going to have an intervention-based palliation or a surgical palliation, I definitely feel there is a role for the CT to plan something.
Yes.
Because I'm unsure about the biochemistry of this patient. So maybe a candidate can, if they can substantiate on that grounds, I think as faculty, we should allow them to do a CT scan. If there is nothing to be done, I think I stand with all of you telling ultrasound is sufficient in a metastatic disease. But otherwise, even in metastatic disease, if there is going to be some alleviation planned in form of intervention, radiological or endoscopic, maybe that's the time CT gives them a roadmap. Maybe the candidate should stick on to the comments of the senior faculty and
absolutely, sir.
Yourself.
Absolutely, sir. This will fetch him a higher marks if he can defend this. If he can defend this. If he can
Dr.
detect
Prem.
this advanced
ahead,
disease, right? Go ahead, Dr. Prem.
Dr. Prem,
Yes, sir.
what is the role of MRCP here?
So as far as this case is concerned, the MRCP has no role, sir. So CBD was not involved. There's no any presence of any stones in CBD.
Fine. So what treatment will you
No
offer now?
chance. Pardon, sir?
What treatment plan will you
Treatment
plan?
since so it is a case of advanced gallbladder malignancies. Patient can be advised for chemotherapy followed by
Without a tissue diagnosis.
How will you get a tissue diagnosis?
You want to give chemo without tissue diagnosis.
tissue. You can go for FNAC biopsy.
Can go. See, don't use the term can go. Can go
Then
is
you can-
different. That's a bad expression.
Since okay, sorry. So since this is a case of unresectability, so we can do FNAC and confirm the diagnosis and go for the either chemotherapy or palliation based on the patient's status.
Prem,
Maybe
the
if
question
there
the
is-
examiners would like to ask is, how will you do an FNAC? Will you do a guided FNAC? Or will you do an endoscopic ultrasound guided FNAC? Or will you do a CT guided FNAC? That is the message. And what are the safety measures you should take in such an advanced case to do a FNAC? If you can outline in a logical way, the examiners are going to move to the next.
Okay, sir. So you can do ultrasound or CT guided FNAC. If the coagulation profile of patient coagulation profile is normal, you can go ahead.
Very important, no?
Coagulation profile, yes.
So after checking the coagulation profile, you can do FNAC.
So what was the stage of this disease on CT abdomen?
So this is case of stage 3B. So involvement of the liver with periportal, hepatic and retroduodenal nodes involvement.
Prem, if it is a lesion confined to the gallbladder resectable disease, in that case, do you like to do a biopsy? You think CT wise it is a resectable lesion. Do you do a biopsy in that case?
No, sir.
You want to do?
No, sir. We can go for definitive surgery.
Okay.
What
Any
is the
role of
reason you want to
diagnostic?
avoid a biopsy? Sir has been asking with a specific point about this question. Is there a role, or what is the reason we prefer to avoid a biopsy?
So it may, so by doing FNAC, it will cause fiddling of the tumor and dissemination of the tumor.
Main thing is a tumor which is limited to the inner linings or the muscularis and not reaching the serosa. By doing an intervention, you end up seeding or contaminating the entire tract, entire layers of the abdomen with the tumor.
Partially gallbladder also.
And one more thing is FNAC gallbladder 100% accurate?
FNAC lacks some.
What is the specificity and of FNAC malignancy? Is it 100% true?
No, sir.
So
80%.
So
no. Students should understand the question. What is the examiner is asking? See, you will not get a grading. You may say positive for malignancies. That is not going to be
positive for
sufficient.
malignancy. That's it. Yes.
So that is not going to be sufficient. All the faculty are helping you to find out. Unless you know the subtype of the tumor, grade of the tumor, this oncologist will not be able to decide the drug of choice. All right. So that is why nowadays FNAC is getting replaced by FNAB. You get a 24 core, 6 core, very thin core, but then that is sufficient for the pathologist to address. You don't go for a thicker core.
All right. So this is what the examiner expects. See, please understand and assimilate when a question is answered rather than jumping to answer. That helps you to answer in a more relevant way. All right. Faculty, please take over. I would like to remind we have another 5 minutes to close because we have one more candidate to present. Thank you, esteemed faculty.
Thank you so much.
So Dr. Prem, now in coming to this
How do you
case,
treat this case?
what treatment will you give to this patient? There are multiple liver regions, right?
Multiple
Yes.
liver lesions.
Yes. So it is advanced malignancy. So what will be?
You can give a chemotherapy, gemcitabine with cisplatin based chemotherapies can be given.
Oh, okay. What is the intent of your treatment? What is the basis of CAGB?
Palliation.
Palliation. Okay. Now, what do you mean by palliative treatment?
You know any special method of delivering chemotherapy to the liver and the gallbladder?
Intra-arterial.
What is it? What is TACE? TACE, TACE.
Trans-arterial chemoembolization.
Yes, exactly. That can also be attempted.
Yes.
If it is confined to the liver and gallbladder.
Okay.
Okay.
Do you need palliation for this patient? Do you think any palliation is needed for this patient?
So for that first, what is palliation?
So the treatment it's aimed at the treatment aimed at decreasing the patient symptoms.
Right. So only patient. It is only for patient symptoms. So which are the symptoms in this case?
So patient has pain. So patient doesn't have any jaundice. So
right.
For pain, we can give a celiac ultrasound guided.
Right. So in this case, that will be the only required for palliation. Okay. Yes. So now just to consider if this patient would have been a resectable disease or would have come to you at an early stage, then what surgery you would advise to this patient?
So if it is a stage 1B or 2, we can go for extended cholecystectomy.
Right, extended cholecystectomy. Very good. What does that mean? What are you removing?
Extended cholecystectomy, we are removing gallbladder with a 2 centimeter section of liver surface from the gallbladder fossa, along with segments of 4B and 5, along with the nodes of pericholedochal, hepatic, and peripancreatic, so retroduodenal nodes.
Okay, all the clearance of hepatoduodenal.
Okay. Prem, if you are doing a laparoscopic cholecystectomy and the biopsy comes out as a malignancy T1B lesion, how will you proceed in that case?
For T1B, it is advised to go for a re-laparotomy and then do a resection.
Re-laparotomy, or you would like to do some other things before going ahead with the procedure? You again do a CT scan, evaluate the location, because it probably is scan where CT may not be done before. You have to stage the disease and then proceed with surgery. Okay. So what surgery will you do? T1B?
T1B, extended cholecystectomy.
Plus?
With the removal of nodes along with the port side excision. Port side excision.
So Dr. Prem, suppose you are excising these lymph nodes. What are the most important group of lymph nodes you see?
Cystic and pericholedochal
You see, pericholecdochal lymph nodes is a very vague. Any other, you see, stations you have, any other classification of lymph nodes, or from where you start your, you see, taking these lymph node dissection? What are the, you see, first step of lymph node dissection in extended cholecystectomy?
We'll remove from periportal nodes.
Sir, I would
Periportal or
request you
somewhere
to
else.
give the answer. Sir, please give the answer. I think he has not
So,
read about it.
you
and
see,
he's trying to-
so it has to be done from below upwards. So cauterization is required. Then hypocaval lymph nodes is given. If suppose you have a select group of lymph nodes and you have to send it for frozen biopsy. If you see it comes positive, then no need for further dissection. So it's already a very advanced disease, right? So it has to be started from below. Started with the cauterization and then proceed upwards.
Okay.
Anything, any role of excision of CBD in these patients? Common bile duct. Do you excise common bile duct? When you excise common bile duct in these patients?
There is any involvement, local infiltration to the common bile duct, we can we can excise the common bile duct.
Or you send some frozen section of cystic duct, and if it comes to be positive, then you remove this part of CBD and do a hepatocytostomy. Yes, you send cystic duct, right? Excision. If it is positive, you excise that segment of CBD and then do hepatocytostomy.
Faculty, I think I have to step in to stop this patient discussion. I'm sorry about it. We are running out of time. We normally give the student to have the benefit of asking any doubts to be clarified by the national faculty. Prem, I think you have to, one thing from my side will be, see, you anticipate more questions and you should be much well prepared. And it's more like not only reading, I would recommend all the residents to plan your answers, right? So if my examiner is going to ask this question, I'm going to answer in this logical sequence. The examiners would only want to know, are you a safe person to leave a patient interested upon you? So for that, I would say a proper staging process, which comprises of. So in this order, every answer should be ordered in a logical way. Then even if you do not know, the examiners may not penalize. Jumping into one or other investigations without a logical sequence will definitely be not an acceptable thing for the examiner. These things you please concentrate, go back to your reading, get back to your theory, how they, see, unless you know what is the progression of disease. See, it is not that you read about metastatic CA gallbladder and come for the discussion. That should be either you should be knowledgeable about how the CAGB progresses. Then all the principles of everyone is liking to know whether you've understood the principles of management of CA gallbladder, right? Yes. This is my comment. Other faculties, please give your comments before we move to the next case. Thank you very much.
Thank you, sir.
Dr. Prem, Dr. Prem, you have presented nicely. Only thing, please remain focused and avoid vague terminologies and very simple mistakes like others have pointed out to you. Rest is okay, and go in a methodical manner. You will not miss unless you skip some important points that should not happen for a PG level. Rest is my best wishes to you. Thank you.
Thank you. Thank you so much.
Thank you, sir. Prasad, sir.
Prem, you have presented nicely, but don't take any diagnosis before, because once you get the diagnosis, your mind won't think. So have a free mind, go directly to the patient, examine the patient, and all the differential diagnosis you keep in mind, and freely, if you tell something, if the examiner think that you already had a diagnosis, already someone helped you, then they will make sure that you will fail. So you should not go into such situation. So always be free and examine the patient. You all give all the differential diagnosis important.
Okay.
Dr. Prem, nicely presented. Best wishes to you. Right.
Thank you. Thank
you. Prem, do you have any doubts to be clarified with the senior examiners here?
No, sir.
Thank you very much. And
Thank you, sir.
give my kind regards to your professors, Loganathan sir and Jawahar sir. Thank you very much for joining. You stay back for
Thank
the
you so much,
second
sir.
case discussion.
Yes, sir. Sure.
And I request Srividya ma'am to switch on your video, share your
Yes, sir.
PowerPoint.
Yes, sir.
Sharvari ma'am, would you like to take the question in the chat box? The candidate has asked, what is the role of CEA and CA 19-9 in advanced hepatobiliary malignancies?
Hello. Yes, I cannot
Yes,
see
ma'am.
the chat box. He has asked
Hello?
about CEA 19-9.
In advanced CA gallbladder.
In advanced CA gallbladder. So in advanced CA gallbladder, it has a little of a role, but in overall hepatobiliary malignancies, you know, these are the tumor markers. These will help you to prognosticate the patient. First of all, in addition to diagnosis, it will tell you about the prognosis. For adenocarcinomas, it will be CEA. So for gallbladder malignancies, it will mostly CEA will be raised. Pancreatic periampullary CA 19-9 will be raised. If these CA 19-9 is raised in terms like more than 1000 and all, then that will indicate that the tumor has already invaded vessels. So maybe it is probably advanced malignancies. The pitfall with the CA 19-9 is that when there is a cholangitis, then it is falsely raised. It is one point to be noted, especially in periampullary with cholangitis. If there is cholangitis, then the CA 19-9 level will be falsely high, and then you have to repeat it. But majority of the times, these tumor markers are used for prognostication. After treatment, the levels should fall, and then if there is any rise in these markers, then you should look for the recurrence of the lesion or metastatic disease with further investigations are needed.
Thank you very much, ma'am. Very brilliantly summed up. So with the permission of the faculty, we move to the next case. Dr. Srividya, please introduce yourself, your unit chief, your head of the department, and start your presentation. Faculty, please take over. Thank you very much. Kana Srividya, are you here? I could see the PowerPoint. Dr. Srividya? Any of her colleagues, Dr. Srividya's colleagues from Coimbatore Medical College, can you check with her, please?
Sir, I'm here, sir. My video is not visible, sir.
No problem, Kana. If you can log in, re-log in, you can do it. Otherwise, we'll be happy to see you when you're presenting. But if that is a challenge, you please go ahead.
Okay, sir.
Please make it a full screen and start presenting.
Yes, sir.
If you have a problem, you present in that same format. Only thing you may need to advance the slide every now and then.
Yes, sir.
On the right lower side, you can see like a screen. Can you try pressing that?
Yes, sir. Yes, sir.
Go back one. Go back. You have come to the last slide. Just press the up arrow. Yes, go back to the first slide. Yes.
Yes, sir.
Sorry, faculty. I could not
I'm
check
sorry,
your
sir.
slides. Okay, good luck to you, ma. All the
Yes,
best.
sir. Thank you, sir. Good evening, everyone. I'm Dr. Srividya from Coimbatore Medical College and Hospital. Today, I'm presenting a case of left hypochondrial mass. My patient is a 17-year-old female came with complaints of pain abdomen in left side of upper abdomen since 7 months, which was on and off. And also complaints of mass in left upper abdomen since 5 months. She also complains of early satiety since 2 months. This is the clinical picture of the patient. History of presenting illness. Patient was apparently normal 7 months ago. Then she developed pain in the upper abdomen, left upper abdomen, which was insidious in onset and gradually progressing, radiating to back, relieved by medication, increased with high fatty diet. And it was also associated with mass in left side of upper abdomen, which was of size 3 into 3 centimeter, later progressed to current size of 12 into 12 centimeter. She also complains of early satiety since 2 months. There was no history of nausea, vomiting, no history of diabetes, hypertension, asthma, or epilepsy, tuberculosis, or seizures. She also gives no history of fever, no history of trauma, no history of abdominal distension, no history of altered bowel habits, no history of jaundice, no history of chest pain, no history of breathlessness, no history of significant weight loss, no history of repetitive and long duration contact with domestic animals or persistent itching. In past history, she has no similar complaints of the same in the past, no history of previous surgeries in the past, no history of any similar complaints in the family too. Personal history, she takes a mixed diet. Now her appetite has been decreased. Sleep is undisturbed, has normal bowel and bladder habits, no history of consumption of alcohol or no history of smoking. Summarizing my history, my patient is a 17-year-old female, came with history of abdominal pain localized to left side of the abdomen since 7 months, left upper abdomen since 7 months, complaints of mass per abdomen in left upper abdomen extending till the epigastrium of size 12 into 12 centimeter since 5 months. Complaints of early satiety since 2 months with no significant history of weight loss, no history of other associated symptoms.
In a 17-year-old patient, what do you think when such a patient comes to you? The abdominal pain and the mass is there. What
Yes, sir.
thought process goes to you through your mind?
First, we thought it can be congenital, sir, but she gives a history of pancreatitis, which was there 7 months ago, sir. And she also gives of on and off abdomen pain.
So, right. So, Srividya, you have now come to the point when you start thinking about the patient, right? So, you said she has history of pancreatitis. So, how the pain of pancreatitis would present?
Usually localized to upper abdomen, ma'am, mostly radiating to back.
Where
Radiating
is
to the
the
yes,
where is the pain? What is the classical description of pain of acute pancreatitis?
she'll be having a constricting type of pain radiating to the back, ma'am. A colicky type of pain.
Is pancreatic pain colicky?
Yes, sir, if it is associated with stones.
So the is that you only said, now you started thinking and you said there is history of pancreatitis. So you should have presented in a better manner to point out that there was history of pancreatitis. How? For that, you should know how the pancreatitis pain is, and you should ask or you should correlate that patient is indicating you that type of pain.
Yes, ma'am.
So what is the pain of acute pancreatitis? Once again, tell me, without leave this case and talk in general, how a patient of acute pancreatitis presents. Acute, say, alcoholic pancreatitis.
Yes, ma'am.
Discuss about the pancreatitis also, whether the patient was hospitalized for pancreatitis, any hospital admission was done, what is the severity?
Yes,
so
sir.
If you would have told us that there was epigastric pain, sudden severe epigastric pain, or lasted for 2-3 days, or patient was taken to hospital, it was associated with vomiting, it required some medications, radiating to back, epigastric pain, that means you are telling something about pancreatitis.
Yes, ma'am.
Then having more relevant rather than now telling patient had history of pancreatitis, right?
Okay, ma'am. Yes, ma'am.
And now sir's question, when you would have colicky pain in pancreatitis? Or
When there is
pancreatitis?
when there is pancreatitis associated with gallstones, ma'am.
Right. So you have to tell something like that. So that will indicate
Yes,
that
ma'am.
history of acute pancreatitis. Okay, proceed.
Yes, ma'am. Yes.
Srividya, if I may ask you, you
Yes,
had
ma'am.
talked about pain only in the left hypochondrium, right?
Radiating to back and epigastrium also, ma'am. I have given it is extending to the epigastrium also.
And did this pain and the swelling occur at the same time?
No, ma'am. The pain started first, followed which the swelling developed, ma'am.
After how long?
After 3 months, ma'am. 2 months, ma'am.
After 2 months.
Yes, ma'am. Yes, ma'am.
Okay.
So what happened with the pain, you could have elaborated it more, that pain persisted over these 2 months, pain got relieved, patient was treated,
Yes,
patient
ma'am.
was hospitalized.
Yes, ma'am. Patient was actually treated in a local hospital, and
is
her
very-
pain was relieved with pain medications, ma'am, with NSAIDs. And she also, after that also, it was on and off. After 2 months of treatment, the patient also had on and off pain, ma'am. That is why she came to our hospital.
Okay, so these points are very, very important. The point to be noted here is that there is a different episode of pain and development of some swelling in the abdomen. So you have to tell the history appropriately and elaborate the pain. Tell the history of tell the significance of pain, that there was intensity, severe pain which required medications, hospital admission and all.
Okay, ma'am. Shall I proceed, ma'am?
Here, I would also like to point out one thing, that when you're talking about gallstone pain, that is a different episode altogether. And a recurrent gallstone colic can lead to pancreatitis. You know how it leads to pancreatitis when there is gallstone colic? Yes.
Yes, ma'am.
So please don't mix the two together. Okay.
Okay, ma'am. Okay, ma'am. Shall I proceed, ma'am?
Yes, yes, please do.
Yes, ma'am.
Hang on.
On general
No, just a minute, Dr.
Yes, sir.
Srividya.
Yes,
What's your
sir.
diagnosis by your history?
Sir,
What do you think you're dealing with?
sir, I think I'm dealing with the cystic lesion arising from the pancreas.
No, again the same mistake. You are jumping on the diagnosis. What information you have to only correlate that much information now. There is some swelling.
There is a mass per abdomen in left hypochondrium extending to epigastrium, ma'am. Probably arising from pancreas, depending on the location, and with the history patient giving maybe pseudocyst of pancreas. Ma'am.
No, hang on.
Yes, sir.
Let's just go back to your past history.
Yes, sir. Yes, sir.
Beyond that.
In history of presenting illness, sir.
Where have you come across, how has this episode of pancreatitis erupted suddenly?
Sir, she was having.
There's nothing in your history as such.
I have
7 months
given
ago
a history
developed
of
pain
presenting illness,
with
sir.
incidence. So aren't you going to elaborate on this?
Yes, sir. I have elaborated. The pain is localized to left upper abdomen.
No, where is the history of that she was admitted and then she underwent treatment for it? Where is all this?
Yes, sir. Yes, sir. Yes, sir.
I mean,
That was
suddenly popped out of a box and you've made a diagnosis of pseudopancreatic cyst.
No, sir.
Yeah.
No, sir.
So let's go back now.
Okay, sir.
Why do you think this is a pseudopancreatic cyst by your history?
Sir, because the location of the swelling, sir.
Where do pancreatic swellings usually present as? Which?
Sir, usually in epigastrium.
Then?
And also even in left hypochondrium. This swelling is in left hypochondrium extending to epigastrium, sir.
Why are you saying it this way? Why can't you say it's a swelling in the epigastrium extending to the hypochondrium rather than the other way?
That is because the patient gives history like that, sir. She said it started in the left side of her abdomen, then it has progressed to the midline, sir.
Okay. Okay.
Yes, sir.
Okay. That is, she's given you this. Why do you think she had an attack of pancreatitis?
Sir, she gives a history 7 months ago. She has developed a left upper abdomen pain and also including the epigastrium, which was radiating to the back, which was relieved by medications and is increasing with the high fatty diet, sir.
After how many days of this episode she developed this lump?
Sir, 2 months, sir.
Okay.
Yes.
So usually when does a pseudocyst develop after an attack of pancreatitis?
So 4 weeks, sir.
So isn't it a bit too late?
It could be a smaller size, sir. She might not have noticed, sir. When it became 3 into 3 centimeters size, she noticed the swelling, sir.
Okay, I'm taking it with a lot of salt. I'm not convinced by your history, but let's go on. Okay. So please.
I'm proceeding with the examination, sir.
Any other diagnosis? Any
Sir,
differential diagnosis?
It can be a mesenteric cyst, sir, or a hydatid cyst. A hydatid cyst of spleen, sir.
No, why are you going on for cysts? Why do you think? Why can't it be a solid swelling? Why do you think it's a cyst? By your history. Because you know the diagnosis, is it?
No, sir.
Then why do you think it's a cystic swelling?
Sir,
Just by history.
Sir, the patient have no history of loss of weight. There is no history of any other history.
Can it be a spleen? Can it be a spleen?
So,
sir, depending upon the location, yes, sir, it can be a spleen.
Yes, so sir is like wanting to tell you that you cannot say it's a cystic lesion unless you know. That means you know the diagnosis. So there is something you have to say, yes, sir, it can be. It can be a solid lesion. It can be a spleen. You cannot say it is a cystic lesion.
Yes, ma'am. Yes, ma'am.
Unless you know the diagnosis, or you have to tell the history very, very clearly, or you have to elaborate the history in such a way that you lead to diagnosis. The history you presented is so vague that anything can be possible.
Yes, ma'am. Understood, ma'am.
Okay.
Yes.
Examination, please.
Yes, sir. On general examination, she is a moderately built and nourished female. She was conscious and oriented to time, place, and person. Vitals were 80, pulse rate was 88 per minute, regular in rhythm, volume, and character. BP was 110 by 70 mmHg. Temperature was 98.6 Fahrenheit. Respiratory rate was 14 per minute. She had no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, pedal edema. On local examination, on inspection, after getting a consent and from the patient, she was asked to lay down in supine position and was examined from nipple to mid-thigh in a well-lit examination room with adequate privacy. Umbilical on examination, the umbilicus was midline in position and inverted. All quadrants of abdomen moved equally moved correspondingly with respiration. A mass of size 12 into 12 centimeter in left hypochondrium extending to epigastrium, which was globular in shape, does not move with respiration. Skin over the swelling appeared normal. No scars, dilated veins, visible peristalsis. On head raising test, mass appeared less prominent. Hernial orifices were free. External genitalia appeared normal. On palpation, it was non-tender. Inspectory findings were confirmed. A mass of size 12 into 12 centimeter into 8 centimeter was present in left hypochondrium, extending vertically 2 centimeter below the left intercostal margin, and lower border was 3 centimeter above and lateral to the umbilicus. In horizontally, it was extending 15 centimeter lateral to the xiphisternum in the left side and 2 centimeter from the xiphisternum to the right side. It is soft in consistency and the surface was smooth. Borders were well defined. Swelling does not move. It did not move with respiration. Insinuation of finger was possible between the ribs and the swelling. This was the patient clinical photograph. On examination, there was no organomegaly, no guarding or rigidity, no palpable nodes. Percussion, dull note was percussed over the mass, and liver span was normal. Liver dullness is distinct from the mass, and no evidence of free fluid in the abdomen. Auscultation, normal bowel sounds were heard, no audible bruit present.
Doctor, why do you say no organomegaly? Because you don't know this swelling. What is this swelling? It could still be a spleen, no?
Yes, but I was able to palpate. On palpation, I was able.
No, you just say that there are no other masses. That's all. Don't
Okay,
say organomegaly is a very general term.
Okay, sir.
Because you don't know what this is, no?
Yes, sir.
Just say no other masses are felt.
Okay, sir.
Yeah.
Okay. On perrectal examination, tone was normal. No mass was felt. Fecal staining was present. Systemic examination, cardiovascular system, system S1, S2 present. In the respiratory system, bilateral air entry was present. No added sounds. In CNS, there was no focal neurological deficit. Summarizing my case, she was a 17-year-old female presented with the complaints of mass in left hypochondrium extending to epigastrium and diffuse dull aching pain in the upper abdomen over the left hypochondrium radiating to back, also including epigastrium, associated with early satiety. On examination, a cystic swelling of size 12 × 12 into 8 cm was present in left hypochondrium is palpable, which does not move with respiration, with well-defined borders, and fingers could be insinuated below the costal margins bilaterally. Provisional diagnosis on history and examination is a cystic swelling arising from retroperitoneum, probably pseudocyst of pancreas.
Did you elicit fluid till for the cyst?
Yes, sir. I elicited, sir. There was.
Did you mention?
Yes, sir. I have mentioned there was no evidence of free fluid, sir.
No. Fluid till over the swelling.
Yes, sir.
Cystic swelling. You should
Yes,
be
sir.
able
Yes,
to
sir.
feel the fluid till, no?
Yes, sir. Yes, sir. I have percussed it, sir.
But you are not mentioned.
Yes, sir. I have mentioned there was only dull note, but the shifting dullness was not there, sir. So I did not mention it specifically, sir.
I am talking about fluid till, doctor. I am not talking about shifting
Cystic
dullness.
swelling could we have a fluid till? If there's a cystic swelling.
It is possible, sir. Yes, sir.
That's what he's asking.
It was not there in this patient, sir. So I did not mention it, sir.
Again, Dr. Sirividya, you have made the same. You have to be very smart postgraduate.
Yes,
you
sir.
see, all these senior professors have, and ma'am has again and again told you to correlate your history of acute pancreatitis in this patient. And in your summary, you have again given the same type of diagnosis without mentioning about her hospitalization or acute pancreatitis. And again, you have mentioned such a big mass present in the left hypochondrium. Just go to your summary. You have not mentioned anything that this swelling is extending. You have just written it is in the left hypochondrium. So you have to, when you are summarizing it, you have to change it very smartly.
Yes,
so that is what a smart postgraduate should act.
Yes, sir.
So same thing as you see previous case.
Yeah, same mistake.
Same mistake again and again.
Correct.
Dr. Srividya,
yes, sir.
Soft swelling in the abdomen. How would you softness? How can you say in an abdomen mass?
Sir, the consistency was. How
can you say soft mass? That is one thing. Second thing is a pseudocyst of pancreas. If you don't have any history of pancreatitis, what other differential diagnosis do you think in a 17-year-old female patient?
Sorry, sir. I didn't get you, sir.
If there is no history of any pancreatitis,
yes,
what
sir.
are the other differential diagnosis do you think in a retroperitoneal mass like this?
Sir, cystadenoma of pancreas, sir.
Which type of
a benign cystadenoma of pancreas, sir.
What type occurs in a younger patients?
Anything else?
It It can be a retroperitoneal cyst, sir.
Like what cyst? Commonest cyst in retroperitoneal
Why
means
you
lymph
are
cyst. It's a
still
lymph
stuck
cyst.
with
Yes,
lesion?
sir. Yes, sir.
That's very
Lymphatic
common.
cyst, sir. Yes, sir.
Yes.
Cystic tumors of pancreas, what type of tumor can occur in a young patient?
Sir, mucinous cystic tumor, sir.
Mucinous, it is in a middle-aged patient. Mucinous won't come in a young patient. Mucinous comes in a middle-aged group. Serous adenoma in old age group. What comes in a 17 young patients? Pen will be there. Okay.
Okay, sir. Okay, sir.
It's the usual tumor in a younger patient.
Okay, sir.
Okay.
Yes, sir. Shall I proceed, sir?
Yes.
Sir, I would like to do certain investigations. First, starting with blood count, sir. A complete blood count, RFT, LFT, serum amylase, serum lipase, serum calcium, chest X-ray, PA view, and X-ray abdomen erect, ultrasound abdomen pelvis to start for my diagnosis, and CECT abdomen pelvis to stage the disease. Yes, ma'am.
Do you
Doctor,
think
very fundamental question I am asking you, doctor. How
Yes,
why
sir.
you want to take a PV of the chest and the APV of the abdomen?
Sir?
Why you want to take a PAV of the chest
Yes,
and
sir.
APV of the abdomen?
Sir,
There is no why.
yes, sir. AP view of abdomen gives us the direct view, sir. Direct view of abdomen. In PA view, lungs is actually located more posteriorly, sir. So it is better to visualize from the back. Front, it is shielded by heart.
No. Your answer is not correct. What is it you are looking at in the chest? You're not looking at the lungs. You are looking at something
Sir, I want
else.
to look for pleural effusion, sir.
No. Don't be in a, you don't want to look at the heart.
Uh,
What is the first thing you want to see when you see a chest X-ray?
First, I want
Pleural
to see.
effusion, 1 in 1,000 case. But every
Yes,
day,
sir.
what do you see? Every day, what do you see? Talk about something common. Don't talk about something very rare.
Okay, sir.
So cardiac stability is what you want to see first.
Yes,
So
sir.
that's more anteriorly placed. That's why you take a PA view.
Yes, sir.
Okay.
So, Sri Vidya,
Yes, ma'am.
you should not put the list of investigations. That these investigations should be relevant investigations, right? So,
Yes,
tell
ma'am.
me the relevance of serum amylase and lipase now in this case.
Serum amylase and lipase is usually not elevated in these cases, ma'am. But if it is elevated, it is indicating that there is association of acute pancreatitis in this patient, ma'am.
Do you think there is acute pancreatitis? When you will think acute pancreatitis, there should be some clinical findings. Na? What clinical findings should be there to think of acute pancreatitis?
She was having on and off pain, ma'am. So I wanted to be sure that she did not have recurrent pancreatitis, ma'am.
Okay. Along with pain, what you would find?
Radiographically, ma'am.
Clinically.
Clinically, there will be tenderness in epigastrium.
So was it there?
No, ma'am. On palpation, it was not there.
Okay. So the point to tell you that you have to think and use the investigations also judiciously. No need, only just because it is pancreatitis, you should not send amylase and lipase unless there is clinical findings of indicating acute pancreatitis.
Yes, ma'am. Yes.
Srividya, what will be your first investigation in this patient? This patient has come to you.
Yes, sir.
What would be your first investigation?
Sir, I would like to do an ultrasound abdomen pelvis.
So why you are telling all that list which is before that? You will do X-ray chest and you will do X-ray abdomen. What you are going to get in that? So you have
Yes,
to say,
sir.
no.
Yes,
no,
sir.
this is
Which
your
I want.
patient.
Yes, sir.
And you have to, first thing you have to make a diagnosis.
Yes, sir.
And for making the diagnosis in this patient where there is abdominal lump, especially, you cannot say it is a cystic lump.
Yes, sir. I cannot. Yes,
Until unless you find
radiological evidence.
No, not clinically. If you find a fluid thrill in that, in the lump.
It was not there.
That is
Yes,
only,
sir.
and which you never get in the case of pseudopancreatic cyst.
Yes, sir. Yes, sir.
It is only present in the hydronephrosis.
Yes, sir. Yes,
That
sir.
you find a dilated kidney is there. You will find
Yes.
that fluid thread will be there in that lump. No?
Yes, sir. Yes, sir.
So
Now you are appearing for MS exam, right? It is not MBBS exam. So
Yes,
what
ma'am.
I think even the MBBS exam will not give that like that. No, now the MBBS are very smart, and they know that.
Yes. So,
And
yes.
ultrasound is an extension of your clinical examination.
Yes, sir.
For an abdominal lump, it is definite it is there. So you have to go for the ultrasound in this patient.
Beginning.
And then
Yes,
you have
sir.
to proceed with the other things.
Yes, sir.
Dr. Srividya, you want to see CT abdomen pelvis. What are the things that you are looking for this? What are the things you're looking at? Why do you want to do a CT?
Sir, I want to look for the size of the cyst and the location of the cyst
Okay.
and the nearby structures to it and wall thickness. Sir.
You keep saying cyst all the time. You are presuming that it is a cyst. First of all, you look, ultrasound will tell you it is solid or cystic. No.
Yes, sir. So ultrasound will tell me the component.
Your mind is fixed on a cyst. That is very bad.
Yes.
You should never fix your mind on a particular diagnosis.
Yes, sir.
Dr. Srividya, on ultrasound, what else you want to see except from this cyst?
Sir, I want to see gallstones if it is there.
Okay, right.
I want to see if any edema is there or peripancreatic fluid. If it is now, it will not be there, sir. Gallstones, I can see a duct. I can see, sir, pancreatic duct dilation. And any free fluid in abdomen pelvis.
Okay, now CT, he is asking for CT. Sir is asking for CT. What else you want to see in CT?
Sir, I want to see the location and the nearby structure.
So you have to say whether it is a cyst or a mass lesion. So it could be a cyst or another differential diagnosis is cystic tumor of pancreas. So it could be that you have to know. So whether it is a just unilocular cyst or is it a mass?
Multiloculated, multiple cysts.
Multiloculated. So if it is a whether it is a what is the radiological signs? If it is a mucinous cyst of pancreas, do you know what is the radiological feature? What type of calcification? Eggshell calcification will be there in the mucinous tumor. Could be so that you have to see. If it is a pseudocyst of pancreas, you have to know with the location of the cyst, again, as you mentioned, the size of the cyst, whether it is a single cyst or is a multiple cyst, again, whether there is any evidence of chronic pancreatitis, underlying chronic pancreatitis, like dilated duct or calcifications. Sometimes the patient might have an acute or a chronic pancreatitis presenting with a pseudocyst.
Yes, sir.
Again, as I already told, the presence of any gallbladder stones, or if there is any biliary duct dilatation, because any sort of edema can produce a dilatation of the bile duct. All these things, you have to, any gastric outlet obstruction, this thing can present. So there are all these things you have to look for it. If you have a doubt of whether it is a mucinous tumor or what investigation would like to do?
I would go for an endoscopic guided fine needle aspiration, sir.
What are the things you are looking in the US?
Sir, sir, I will look for the location of the cyst and the wall thickness, and I will do an FNAC to see what is the content of the cyst, sir.
Okay, you're aspirating. What are you looking for?
I want to do biochemical tests in the aspirate, sir. Okay. I will look for amylase.
Okay.
And CEA, sir.
Okay.
And
so it comes out as a low amylase, high CEA. What is your probable diagnosis? Any other thing?
Mucinous adenocarcinoma.
Mucin, it's high mucin content. So there should be high mucin content, a low amylase, high CEA level. Okay.
Level. Yes,
if the amylase is low and CEA also low, what do you think?
Amylase.
Amylase also low, CEA also low, and not much of mucin.
Yes, sir.
So what is your probable diagnosis? Could be serous cyst adenoma.
Oh, yes, sir. Yes, sir. Yes,
What
sir.
do you expect in
Yes.
this case?
In this case, depending on the history of the patient, I would expect a pseudocyst which is having increased amylase levels, sir, low CEA levels.
Okay.
Yes, sir.
So why do you need the location? What is the importance of a location of the cyst? You're repeatedly telling why do you want to look at the location of the cyst?
Sir, to progress with the plan of the patient, sir, how to treat the patient, our surgery depends upon the location, sir.
Okay.
You want to see something else like wall thickness?
Yes, ma'am. I want to see the size of the cyst, wall thickness of the cyst, location of the cyst, so that I can plan the next management for the
What
patient.
will be next management?
You have to check for the lining of the cyst. You have to
Yes,
see
sir.
for any mural nodules which are there or not. Okay, that can tell
Yes,
you that
ma'am.
it is what you're dealing here.
Yes,
Any
sir.
CT images are there for this patient? Do you have CT
Yes,
images?
sir. Yes, sir.
So here, what do you think? How will you proceed?
Sir,
So describe this CT. Can you
yes,
read? Can you
Sorry,
tell
ma'am?
about this CT scan? Any one film you can tell about that? You can describe?
Yes, ma'am. This is a contrast enhanced CT of abdomen pelvis, showing a cystic lesion in left hypochondrium, extending, almost compressing the spleen and pancreas, extending to the midline, crossing the midline to right hypochondrium, crossing the midline to epigastrium.
Here it is a CT scan, okay? So it is not epigastrium and right hypochondrium and all.
Crossing the midline, ma'am.
What about the relation to diaphragm?
Sir, it is
The reason I asked that
well
question
above,
is
sir. It is
such
compressing the
a
diaphragm.
big cyst in relation to diaphragm
Yes, sir.
Okay.
should move with respiration. You said it doesn't move with respiration.
But it did not move, sir. That's why.
Okay. You told us the relation with the spleen and pancreas, but what is more important as a treatment point of view?
The stomach, ma'am.
Yes. So you have to tell that what it is clearly showing, and that was there in your presenting complaints also.
Early satiety was there. Yes, ma'am.
Yes.
Yes,
So
ma'am.
what does that indicate and how it correlates here?
It is compressing the stomach, so it will be in close approximating to the stomach, ma'am, and we can plan accordingly.
What are you planning here?
Sir, giving the size of the swelling, large size of the swelling, sir, and looks like it is in tail of pancreas since it is compressing the spleen, sir. Maybe extending to splenic hilum. I would go for cystogeginostomy, sir.
Now you don't use the word swelling. Now you have a CT in front of. Now you have a diagnosis of a cyst.
Yes,
now
sir.
you can
Now I
use the
can
word
use the
cyst. You were
Yes, sir.
using cyst since you see the presentation since your
Yes, sir.
and now you have switched on to swelling. So cyst.
Yeah.
Cyst, sir. Yes, sir. Yes,
The other
sir.
thing you can say is I'll do some internal drainage. Don't say jejinostomy. It could be gastrostomy, could be depending upon the situation, no?
Yes, sir.
So
Yes,
you say
sir.
I will do some kind of internal drainage.
Yes, sir. Yes, sir.
So here, do you know surgical or do you have any other sort of intervention? Do you have any endoscopic methods also available?
Yes, sir. We can go for an endoscopic cystogastrostomy.
So why did you say cystogeginostomy? In endoscopically you would do cystogastrostomy, and in open surgery you would do cystogeginostomy. Is it like that?
No, ma'am. I would actually go for a cystogeginostomy in this patient, so because it is looking like it is in tail of pancreas, And to avoid the anti-gravity drainage, we can go for a dependent drainage to the jejunum, and the cyst is large. If it is drained in stomach, the anti-gravity force, it will not be drained properly.
Actually, this is a large cyst. It is in the retrogastric area. You can very well do a cystogastrostomy.
Yeah.
So this is
Endoscopic.
totally
Endoscopically, you can drain it.
even endoscopically possible. You can do a cystogast. Normally, when you do an endoscopy, you can see the cyst compressing the posterior wall of the stomach, and you can see that. So you have to put the drain. So you can do a cystogastrostomy, or you can go ahead with a surgical surgical drainage also is possible.
Yes,
so whatever the entire cyst will compress after it will reduce after your internal drainage procedure.
Yes, sir. Yes, sir. Yes, sir.
What is the most important thing you will judge before doing a surgical intervention, before you do a cystogastrostomy?
I want to see if there is communication to the pancreatic duct, ma'am.
Or would you not like to see the wall of the pancreas? Sorry, the wall of the stomach, whether it is ready or not?
Yes, ma'am. Yes, ma'am.
How will you assess that?
I would do an endoscopy, ma'am, to look for the posterior wall of stomach.
But you were talking about the ultrasound and you were talking about wall thickness. Doesn't it help you?
Ultrasound, yes, ma'am.
Even simple percussion you can identify.
Yes.
So what will be the concerning factors, or what will be the contraindications to do endoscopic cystogastrostomy, or what are you worried of? Those things you will look for.
Gastric varices, ma'am.
Varices, there are varices.
Ma'am? Sorry,
are they called as varices?
What are the points you think that she has varices?
No, sir. She does not have varices.
So from your history examination till now, there was no mention of varices. Now suddenly you have come out with the varices. So as a postgraduate, don't try to jump here and there for these things.
Okay, sir.
This will, you see, you are laying a trap for yourself.
Yes, sir.
Talk about this patient only. Yes.
Okay, sir. Okay, sir.
So as ma'am has asked, what are the, you see, contraindications for doing endoscopic cystogastrostomy?
Contraindication. If the cyst wall is more far away from the stomach, sir.
Okay.
More important thing is, suppose it is a neoplastic cyst.
Yes, sir.
You will not just do an internal drainage and leave it, no?
No, sir.
So that is one of very important things before you plan for a cystogastro or any drainage.
Yes, sir. Yes, sir.
It should be a simple cyst, not a neoplastic cyst.
Yes, sir. Yes, sir. Solid compression of it. Yes, sir.
Any role of laparoscopic cystogastrostomy here?
Laparoscopic cystogastrostomy, I have not heard of it, sir.
Okay. You should go to YouTube and watch the videos of laparoscopic cystogastrostomy. It is, it can be done in such patients where you see endoscopy is contraindicated, or such a big cyst which is bulging into the posterior wall of stomach.
Yes, sir.
Okay, so just to tell you what sir has said, the treatment for this cyst is some kind of internal drainage, right?
Yes, ma'am.
So you have to tell that I will advise for internal drainage. Now, internal drainage in such a huge cyst, very well pushing the stomach, you would first think of cystogastrostomy. And cystogastrostomy can be done endoscopically, laparoscopically, and traditional surgically with open surgery.
Yes, ma'am.
If you have not seen endoscopic, laparoscopic, you can just say open surgery. I will do open surgery and cystogastrostomy. Perfect. It is absolutely right. With the advancements in technology, you can do it with endoscopy. For endoscopy, you could ensure first that cyst is well approximated to the stomach and there are no dilated varices or dilated vessels, but these are not called as really varices unless there is portal hypertension.
Yes.
Okay. And if the cyst is very far away from the stomach, then comes the role of cystogeginostomy.
Yes, ma'am. Yes, ma'am.
So that should be your answer.
Because cystogeginostomy is a bigger procedure compared to cystogastrostomy, no?
Yes, sir. Yes,
So
sir.
think of a simple procedure. Suppose you open the cyst and find it is full of blood. Then what goes through your mind?
Sir, pseudoaneurysm rupture.
No.
Or
Yes.
erosion of pseudocyst into the nearby vasculation.
Pseudoaneurysm rupture is very common.
Yes, sir.
Sometimes it can produce, it comes through the pancreatic duct and produce what is that called? Hemorrhage, gastric
yes, sir.
upper GI hemorrhage.
Upper GI hemorrhage.
What is it? What is the name given to it?
Name.
Succus entericus pancreaticus.
Yes, sir. Yes, sir. Yes, sir.
Srividya, have you assisted any cystogastrostomy?
I have seen systems.
What is one of the important steps that you will do in a cystogastrostomy?
Sir, we should look for the contents of we should drain the entire cyst and look for any solid contents are there, necrotic material is there inside the cyst, sir.
One of the important steps you shouldn't forget is you have to take a biopsy of the wall itself. When you do a cystogastrostomy, why do you want to take a biopsy?
Here again, to rule out a neoplastic
neoplasm
cyst,
of pancreas. Yes, sir.
Yes.
What is there to think? Why do we do biopsy? Always to rule out malignancy.
Yes, sir. Yes, sir.
Then,
sorry.
Okay.
You're talking about internal drainage. Do you do external drainage in any situation?
Yes, sir. If the patient is too sick for an internal drainage and if we see the infection of infected pseudocyst, we can go for external drainage, sir. And if there is no pancreatic duct communication.
What is the problem with external drainage?
Sir, pancreatic fistula, sir. Pancreacutaneous fistula can be formed, sir.
If it is a chronic pancreatitis, what surgery will you perform? So, pseudocyst.
I would go for a
pancreatitis.
Sir, sorry, sir.
There is an underlying chronic pancreatitis with a pseudocyst. What surgery would you prefer?
Sir, cystogeginostomy with the Roux-en-Y, sir.
You have to do a drainage of that. Pancreatico-jejinostomy also should be combined if there is a chronic pancreatitis.
Okay, sir.
Okay.
Okay, sir.
So generally pseudocyst, when it will develop, how, as per the definition?
Sir, after 4 weeks of an acute episode.
If there is a collection before 4 weeks, what do you call?
Acute peripancreatic fluid collection, sir.
Acute fluid collection. Okay.
Yes, sir.
Okay.
Why is it called
Srividya, in these pseudocysts, when you like to follow these pseudocysts and don't do anything?
Sir, when the duration is less than 6 weeks and size of the cyst is less than 6 centimeters.
Okay.
And it is not communicating to the pancreatic duct.
Okay.
Associated with acute pancreatitis, not chronic pancreatitis, sir.
Okay.
Is there any role in it?
Now you answered the first question.
Ultrasound guided aspiration?
In this case, sir?
In any case, is there any role at all?
Yes, sir. If we have doubt in diagnosis, we can go for ultrasound guided aspiration, sir.
No, not only diagnostic, therapeutic. Ultrasound
Therapeutic
guided
also. Yeah,
inspiration.
sometimes we do that also.
Pigtail
Smaller
insertion.
cyst.
Yes, sir. We can go for a pigtail insertion.
And then only if it reforms, then we think of surgery.
Yes, sir. Yes, sir.
What you see? What are indications in pancreatic pseudocyst for definite you see procedures?
Sir, if the cyst is more than 6 centimeters and the wall thickness is more than 3 mm and a cyst is causing symptoms to the patient like early satiety, compressing the nearby structures, or a complicated cyst with infection and
Suppose
rupturing.
this patient had gallstones along with this pseudocyst. What would have been your procedure of choice? Dr. Shrividya?
Yes, sir. Yes, sir. I'm here, sir.
Suppose this patient has gallstones
Yes, sir.
also. What would
Yes,
have
sir.
been your procedure of choice in this patient?
ERCP, sir.
Definitive surgery.
ERCP and drainage.
What it will do to gallstones? What ERCP
We
will
can
do to gallstones?
extract the gallstones outside.
Okay, you can extract the gallstones through ERCP?
If it is in, no, sorry, if it is a pancreatic stones, I can extract, sir.
So I am talking about if she has gallstones along with this pseudocyst, what will be the procedure of your choice?
So first I will go for, to relieve the symptoms, I would go for cystogeginostomy with the Roux-en-Y and cholecystectomy, sir.
As per your history, you are
Yes,
giving
sir.
history of acute pancreatitis. She had
Yes, sir.
attacks of acute pancreatitis. Suppose
Yes,
these
sir.
were gallstone induced pancreatitis, and she had a pseudocyst after that. So
Yes, sir.
such a big cyst along with the, can you do some lab chole and laparoscopic cystogastroscopy in a single stage in this patient?
Yes, sir. It can be done, sir.
Can go. Yes, sir. We can go. We can
Yes,
go
sir.
for lab chole with laparoscopic cystogastroscopy in this patient in a single sitting.
Okay, sir.
How do
your
you
answer.
How do you handle pseudocyst, pseudoaneurysm rupture with hemorrhage? How do you handle that?
So we should go for an angioembolization of the splenic
Very
artery.
good, very good. That's very commonly done.
Yes, sir.
Okay.
Yes,
Sir, anything else, sir? Faculty, please.
Yes, Dr. Srividya, there is one very, very basic and simple thing that I had noted in your slides.
Yes, ma'am.
At the PG level, you are not supposed to make spelling mistakes, right?
Yes,
so if you
ma'am.
go back to your slides, you will see the chief complaint. I would be happy if you could correct that spelling.
Even the first slide also, there are a lot of typographic errors.
Okay, sir. I'll correct it, sir.
Go to the first slide, very first slide.
Yes, ma'am.
And you must also know what is the difference between since and far. Okay, in the same slide, if you see, go to
Yes, sir. Next slide. Sir.
Since 7 months, is it? Is that the correct?
Yes, sir.
Is that the correct thing?
For 7 months. Sir.
Yeah, it should be far, you know?
Yes, yes, sir.
Since is for a fixed duration.
Or you can say of 7 months duration.
Yes, sir. Of 7 months duration. Yes, sir.
Go to the first slide. You see capital letters, Srividya, everywhere you all messed up the capital letters. No?
Yes,
sir. Coimbatore Medical College, Hospital, they are all capital letters. Yes. All these things you should learn, no? You can't make mistakes like there are shabby mistakes like that.
Yes, sir.
When you see the slide, the first impression we get, this girl is not familiar with English. And the impression, you should not give that impression to the examiner.
Yes, sir.
Do not use the word old for a 17-year girl.
Yeah.
Yes, sir.
Old is not a good. Yeah.
No,
old
Yes,
is-
even if it is 70 also, we should not say old.
Sir, will not say, sir. Yes, sir.
Better to say
17-year-old. Yes,
age,
sir. Yes. Old
age,
is still coming, sir.
an
17-year
elder-
aged female.
Yeah,
Yes.
a male aged 70. That's something like that.
Okay, sir. Okay, sir.
There's another thing I would like to point out. I
Yes,
think somewhere you had written liver dullness is distinct from mass. I
Yes,
don't know how
ma'am.
clear it is. I think
Because
you
it
should.
was extending to the epigastrium, ma'am. I wanted it to be separate from the liver, ma'am.
So I think that should be rephrased. Liver dullness
Sure,
is
ma'am.
distinct from mass. And
Yes,
you
ma'am.
mean this on the left side or on the right side?
Right side, ma'am, because mass was expanding to the epigastrium.
So that is where you have not elaborated. So we will think, if you're talking about a left-sided mass, we will think you're talking about liver
yes,
dullness on the left side.
You should
So
talk about
see, it is
splenic dullness. You should talk
ambiguous.
about splenic dullness.
Yes, sir. Yes, sir.
Now, last question. What is the surface marking for spleen, normal spleen?
Sir, spleen extends from the fifth intercostal space to the.
From where? From where? From where?
Sir?
Surface marking for normal spleen, ma.
So spleen, not liver.
Surface marking, surface marking.
Surface marking of spleen, sir.
Yeah, come, tell us completely.
Sir, the lower border of the spleen is extending from the left lower costal margin.
No, you talk about the intercostal spaces, no?
Yes, sir.
What
in the left side.
interspaces? You see how you get caught?
Yes, sir.
Such a simple thing you get caught.
From
It is
the
9, it is
10th,
9, 10, 11 interspaces. In what line? Anterior, middle, posterior axillary line.
Yes, sir.
Where? Which line?
Sir, 9, 10, 11 intercostal space in mid axillary line.
No, posterior axillary.
No.
Posterior axillary line.
Posterior.
See, such a good student, how you get caught in a simple thing like this.
Yes, sir.
That means you are not preparing the basics well.
Yes, sir.
Dr. Shrividya, what is pseudocyst of pancreas?
Sir, pseudocyst of pancreas is defined as peripancreatic fluid collection more than 4 weeks from the acute pancreatitis, lined by a connective tissue, so fibrous tissue.
Okay, where this
Without
EC
epithelium.
gets collected most commonly?
Sir?
Which sac? Some sac? This fluid gets collected?
Fluid gets collected in sac, sir.
Which sac?
Lesser sac.
Lesser sac.
Lesser
Why
sac,
don't
sir.
you say that? Lesser sac. Yes.
Lesser
Collection
sac,
of
sir.
fluid in the
Lesser
lesser sac.
Yes, sir.
Yes, it's collection of fluid in the lesser sac.
Yes, sir.
So what happens to the, you see, why this fluid gets collected into the lesser sac? Why it doesn't go to the greater sac?
Sir, it is below that, sir. The dependent part is lesser.
No.
No.
And there is
How the
communication to the.
What is
yes,
that communication?
What is the communication between
communication,
greater sac and the lesser sac?
What is that communication called?
What is that communication called as?
Foramen Winslow.
Yes, sir.
That gets
So
blocked.
why the yes why this fluid doesn't go to greater sac now?
Sir, because it is in the front and it is not having any communication to the pancreas.
No, beta,
It
because of inflammation it gets, there is edema, it gets blocked. This is what sir has said. So the fluid from lesser sac doesn't go into greater sac.
The foramen Winslow gets blocked, yes.
Yes, sir. Yes, sir.
Because of the inflammatory reaction.
Yes, sir.
Because of inflammation.
Yes, sir.
Okay, very good.
Well
done. Well
Thank
done,
you, sir.
Srivijaya.
Thank you, sir.
Very nice
Keep it up.
presentation.
Know your basics well.
Yes, sir. I will,
Now,
sir.
before you conclude, I'll talk about the spleen. The easy to remember is 1, 3, 5, 7, 9, 11.
Yes, sir. I was just confused with liver.
Yeah,
yes,
the dimensions are 1 inch into 3 inches into 5 inches.
Yes,
7
sir.
ounces in weight,
Yes, sir.
and 9 to 11th interspaces.
Yes, sir.
Okay, easy to
Okay.
remember.
Okay.
Right. Thank you. Good night.
Thank you, sir. Thank you, sir.
Thank you.
Thank you, ma'am. Thank you, ma'am.
Thank you, beta. Best wishes
Thank you,
from
sir.
our side. And I'm
Thank you,
thankful
sir.
to all the faculty to interact with all of you from all over the country. I'm so
Thank you, sir.
thankful to
Thank
you.
you.
God bless us all.
Thank you,
God
sir. Good
bless us
night.
all.
Good night.
Thank you. Good night, sir.
Thank you.
Good night. Good night. Good
Thank
night.
you very much.
Thank you, ma'am. Thank you.
Dr. Please, Srividya, do you have any questions to clarify?
Sir, no, sir.
Okay.
They have answered all my
Faculty, personal thanks to everyone who has stayed till the late evening.
Sir,
Kanna
thank
sir, Jishan ma'am, Mansoor sir,
Thank you, sir.
Karnakaran sir, Sudhir sir, Rajiv Sahai sir, Sharvari ma'am, and all the
Thank-
senior faculty and my dear students, especially Srividya and Prem. Thank you for making this evening a worthwhile learning experience.
Thank you,
Good night,
sir.
everyone.
Okay, good night.
We look